Hello, I'm Dr. Omar Bay, and this is OBHealthy Physicians Health Network. Welcome. And I'm just so glad that everyone could be with us today. We'll have physicians joining. We have several physicians that are at the hospital, and I know that we have some physicians that are in surgery, but they'll be joining us as they become free. And look forward to their conversation and answer and their ability to answer the question. We're a group of Black physicians that are dedicated to improving health for the African Americans. And hold on just for a second. Give me a second. I got one of the docs calling in. All righty. Hello. Yeah. Will do. We'll resend the link right now. Thank you. Okay. Rob, please resend it. All right. Excuse me. So what we'll do is we will start over again. I'm sorry about that, but that's how docs are. We're busy and we come in and out. Dr. Atherley, can you hear us? Okay, he's on the phone as well. So we're going to move forward. All right, we're a group of African American physicians that our goal is to improve health for anyone who is of African descent. Number one. Number two, we are involved with encouraging Black males to become doctors. And that's so important because our numbers are low at this particular point. Our webinar is every second Saturday of the month at 1 o'clock. And I enjoy these webinars so much that I trust that each and every one of you will come back each month and tell their friends, families, church members about it so that they can enjoy it and become educated as far as medicine is concerned as well. All righty. If you've missed our webinars, you can always go to our YouTube channel, OBHealthy, and see any of the past webinars. Please type your medical questions in. All right. What I'm saying is that we are talking about many topics, but if you have a question, and our topic today is pediatrics. All right. So I know that you have plenty of questions about children and your child and maybe grandchildren or a niece or a nephew. Ask your medical question, type it in so we can answer your question. All right. The most important thing that I can say today, please do not change any aspect of your medical care before you consult your physician. Only your doctor can truly take care of you medically. All righty. And the docs are coming in now. And what I'm going to do is I'm going to let them come in and we will give them a moment to get their computers together. All righty. First, what I'd like to do is, and I know that our topic today is pediatrics, but Dr. Clark and I earlier was talking, and Dr. Clark, we talked about a topic, and just to get things started today, how do you approach your physician if you're going to go to surgery? What do you ask your doctor? How do you prepare mentally, physically? You know, what do you have to do to make sure that you're your best when you're going into surgery? Dr. Clark, can you give us some idea, and then we'll go into the main topic a little from this Dr. Brock.
Absolutely. Glad to be here. I think the first thing that you have to do is be completely clear on what operation is being suggested and why that operation is being performed. I think many times patients are not fully aware or fully understand the implications of the disease process and why a particular operation is being suggested. So I think that's the first thing, is to make sure all your questions are answered and for you to know what the risks and benefits of the particular procedure that's being proposed. After that, you have to understand what the actual details of the operation are. So having a breast biopsy is different from having a colectomy. And the implications are what risk is involved in each of those different procedures. and what potential complications can happen. So that aspect of it should be fully disclosed, and you should be comfortable with what you're hearing from the physician. Specifically, you can ask your doctor, a typical question is you can ask how many of these procedures they've performed. You want to get a comfort level with the physician, especially with procedures that are more complicated, is what their experience is and what their anticipation of my experience going through that operation, what potential complications or risk factors I may have that may or may not be or contribute to my ability to get through that procedure. So I think that's probably in a nutshell the most important things that you should be looking at, is understanding why I'm getting the operation, understanding what the operation is in detail, and understanding if there's anything in particular that may put me at risk of not successfully getting through that operation.
Very good. Very well covered as well. I know from a pulmonary standpoint, I'm asked frequently to clear, and then we always say clear the patient for surgery. And I think that's important as well, to understand your medical problems and what may be a potential problem for the surgeon or for the anesthesiologist to get you through the surgery. And from a pulmonary standpoint, we use pulmonary function test, which gives us the ability to understand the function of the lung. And we use the chest X-ray or the CAT scan to identify any particular problem structurally that may have a patient develop difficulties during surgery. And that helped us, I think that helps you guys as far as surgeons are concerned, to be comfortable that you can get the patient through. Dr. Atherley, since we're on this topic, how do you approach it? Because I know that often cardiac situations can be a potential problem during surgery. How do you handle that to make sure that the patient is prepared for surgery appropriately from a cardiac standpoint?
Okay, thank you for asking. I very often am asked to clear patients for surgical procedures, and the requests come from the surgeon based upon the procedure he's about to perform, but the requests also come from the anesthesiologist, who are concerned about not only putting the patient to sleep, but waking the patient up after the procedure.
Right.
So patients with known heart disease or suspected heart disease are often referred to me for clearance, so that I can compute, calculate, and determine the risk for the patient. And I often identify it in terms of the cardiac risk with surgery, defined as low risk, low cardiac risk, low heart risk, moderate, or high risk. And there are a few basic diseases that can give us problems at the time of surgery that we need to be clear on, and we need to optimize the patient, get the patient in the best possible state for these. One, of course, is congestive heart failure. That is a weakened heart, a heart that is not pumping adequately. This may be depressed with certain anesthetic agents, depressed at the time of surgery, and may be difficult for the patient to properly recover if these are not controlled. So congestive heart failure is one of the things. Another is heart attacks, right? A recent heart attack or the potential for a heart attack based upon some of the underlying problems that the patient may have. So I also look at the patients to try to reassure myself and the surgeons and anesthesiologists as to whether or not there's going to be any difficulty in regard to the blood supply to the heart, and whether or not the heart has been damaged or is threatened damage from a heart attack. Arrhythmias or irregular heartbeats are another concern. Patients may develop arrhythmias, irregular heartbeats, rapid heartbeats, or even slow heartbeats at the time of anesthesia, pre-anesthesia, and of course in the recovery phase. So these, again, we have to ascertain, look at the risk, look at the treatment, and optimize the patient's status for these. Those are the major heart considerations that I have when preparing a patient for a surgical procedure, and in fact, when clearing the patient and defining that the patient is not at too high a risk for performance of the surgery.
Yeah, thank you.
Going back to the discussion, so after that patient with known heart disease or risk factors sees Dr. Athley, and we have that information, the discussion, again, when we sit down with them, that 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 important information now factors in. So if it's an elective procedure, which most of the time these cases are, if there are alternatives to an operation or non-operative therapy, those now may become more important or play a bigger role, especially in a patient with a high or almost prohibitive cardiac risk. You have to discuss some of those other options because that may be a better option sometimes for patients who are at very high risk. If there's no other option and they're at higher risk, then you pretty much have to proceed. And with that information, there are things that we will do or potentially do differently. So blood loss at the time of operation, we're always very careful, but even more so in these patients because they can't tolerate any sort of acute anemia. And we may do things to monitor the heart functions intraoperatively so that we can keep things within a certain window, so to speak, so that it limits the amount of complications in these patients. So it's very important that information that we get back from Dr. Athley that may change how we approach that patient.
Right.
The point that you've made is an important one, Kevin, because the determination as to whether or not I give the go ahead and say yes, do surgery or not only depends upon the heart situation, but it depends on the urgency of the surgery. For example, if you tell me that there's surgery that needs to be done very soon, or else the patient may be at increased danger, then I may be prepared to clear the patient to give the go ahead for the surgery, even though the risk may be higher than I'd like. On the other hand, if it is purely elective or can be done when the patient is stable from the heart viewpoint, then I take the opportunity to do some additional tests. Very often I'm forced into trying to order tests and do tests to define the status of the heart before doing the surgical procedure. But if the procedure is urgently required, then I may have little choice but to say, go ahead, the patient is at higher risk, but go right ahead because the surgery is mandatory and it's urgent that you do it. Therefore, go ahead, but with the understanding that the patient will be at a higher risk.
Excellent, excellent. I know that Dr. Court, we have to get you to join this conversation because there are a lot of times then medical clearance needs to be on the chart before the patient goes into a surgical procedure. You're still on and on mute, but can you give us your opinion as to how you approach that? And I know that renal problems, as far as the kidneys are concerned, there may be thyroids that you may have to check. How do you handle clearing a patient from a medical standpoint?
Don't forget diabetes too.
Yes, that's important.
Anyway, very often, like my colleagues have said, we are asked to clear patients. And the first point of entry in terms of that scenario is to send them to the medical doctor. And normally what I would order would be a CBC, a BMP, and an EKG and a chest x-ray. And quite often we find from, especially during the EKG, that the patient may have had a heart attack and don't even realize it. So that triggers a referral to the cardiologist. Things that are very important to me would be the patient's blood pressure. If the patient's blood pressure is very, very high, and unless it's with dire emergency, that patient will not be cleared until the blood pressure is within an acceptable range. We look for cases where the patient may have had a bleeding disorder, because you go into cut someone, you must realize or must clear, in my opinion, that the patient does not have a bleeding disorder. So ultimately, I may refer the patient to a hematologist to do the workup. In terms of that, we'll order a PT, PTT, and sometimes a bleeding time. In terms of heart, Dr. Athley already covered what we need to do. He would have to do EKG, and he will determine whether or not the patient can be cleared. Smoking is also a factor. We may get a pulse ox and certainly refer them to a pulmonologist depending on the seriousness of their oxygen saturation, etc. Ask them if they've had any problems with anesthesia in the past, if they had any difficult problem if they had an arrest or anything similar to that. Those would be the major things that I would be looking at. Blood pressure, blood sugars, problems with anesthesia previously, and what the cardiologist thinks in terms of a whole septal infarct.
Mhm. Yeah. What about allergies? You know, there's so many patients that are, you know, and you may not even be aware that they have allergies or something like that, but allergies is a big component as far as respiratory is concerned. I know there are medications, certain blood pressure medications that people can't take, and you know, we worry about that, especially when you have a patient under sedation for a long time, several hours, that make sure that their airways stay open and clear. Dr. Anderson, we're going to get you involved with this. I mean, you, I'm sure will come in contact and do come in contact frequently with the type of patients that you take to surgery. They're usually, you know, long cases and type of cases that the anesthesiologist has to work very closely with you. Can you give some insight into how you keep the patient safe and during surgery?
Yeah, I think, you know, the narrative, especially of late, you know, surrounding safety and outcome is important when you do the kind of work that, you know, Kevin and I do. And even when we talk about an interventional cardiologist, you know, he oftentimes has to get involved in doing invasive procedure in order to get information that we need. And I liken the whole issue of medical clearance prior to surgery to flying an airplane. All right, the takeoff has got to be perfect, the flight has got to be really good, and the landing has got to be exceptional. And sometimes we have to question our motives. What are we asking our colleagues to do when we ask them to clear a patient medically, right? Because sometimes, you know, the message is, oh, I just want to have someone to help me share a risk. And that should be the wrong approach. The right approach is, how do you keep the patient safe? And, you know, all the measurable parameters it's multifactorial. And we talk about pulmonary, which is evaluating the lung. We talk about blood pressure. We talk about heart, and that's the cardiovascular part of it, you know, the heart and lung. And then there's the physiologic issues, right? The thyroid, the diabetes, the high blood pressure. Because at every phase of surgery, each of these conditions can become paramount. You know, one of the things we don't realize, you know, patients, when they get induced or put to sleep, they often spike, the blood pressure often go up. So if their blood pressure is marginally elevated to begin with and not well controlled, you know, that's a perfect setup for them to have a stroke. So that's when we lean on Dr. Court, you know, and then during the flight, you know, we rely on the oxygenation of the lung and the proper functioning of the heart. And oftentimes what I need from Dr. Atherley and, you know, Dr. Court and yourself is how to help Kevin and I manage these patients during surgery, because you guys are not there. And when we do these operations, we need to give you some directives. You know, is it urgent? Is it emergent? Or is it elective? If it's emergent, it kind of doesn't matter. We jump in the water and we manage the patient the best way we can. If it's urgent, which means we have a little bit of time, but we have to get it done, we be as expeditious as we can to get the most important pieces of information. And then the landing phase of it is, now it's surgery's over, how do we get them through the next 48 or 72 hours? Because believe it or not, that's a critical part of it. That's when all the fluid shifts occur and the stress on the hearts occur. And that's when all the swelling and edema around the airways occur. And how do we manage that? So, you know, it's complex, and we have to ask ourselves, what are our motives when we ask you to do the things we want you to do?
Yeah, excellent, excellent. Any other aspects? Because I have some other topics that I want to cover.
There's a quick question there.
Yeah, just on the point. Okay, I'll just mention very quickly that Patrick just raised an interesting point that's occurred to me once or twice. That during the surgical procedure, there can be problems that occur that require my intervention. And the most striking I remember is a patient whom I saw maybe 10 years ago, and up to recently I saw him and reminded me of it. We met when he was under anesthesia getting kidney surgery. And at the time of the kidney surgery, the anesthesiologist realized that there was something wrong with his electrocardiogram. Obviously, the patient was out of it and couldn't complain of the pain. The electrocardiogram showed signs that suggest to us an urgent and immediate heart attack occurring, acute myocardial infarction, as he called it. And the patient was rushed from the operating room down to the cardiac catheterization, where we were prepared for him and put the patient on the table and opened up a blockage which was occurring in one of the vital arteries of the heart. So we fixed that and then readied him for a later reappearance for his intended surgery. But I don't know if I don't think he actually underwent the surgery after all. We stopped that surgery, but we did do the surgical procedure to correct the heart problem, which was causing him a heart attack there and then. So problems during the flight, as you mentioned, can occur, not just the preparation before and the landing, as you put it, after. That was intriguing.
Kevin?
Oh, no, there's a question on the board. What about
Yes.
individuals who have high cholesterol prior to
High
surgery?
cholesterol.
And I would
Yeah.
add, what about individuals who have high blood sugars? So Dr. Cord or Dr. Athley?
Well,
Go ahead.
Are you referring to prior to surgery or during surgery?
Prior to surgery. So if their blood sugars are not controlled well and they have hypercholesterolemia.
You have to control the blood sugar to the best of our ability. Certainly with short-acting insulin, it
Mhm.
works.
Yeah.
From
In terms of
From my-
cholesterol, it may not
Mhm.
pose a problem initially, but long-term also, generally patients with high cholesterol, you always think of heart disease. And for that, we'll refer to the pre-admission EKG to see if there are any EKG changes. And if so, if the patient needs to be seen right away by the cardiologist or not.
The concern I have for cholesterol, of course, has been articulated by Dr. Court, and that is the long-term effects of the cholesterol. When a patient mentions to me that they have high cholesterol, it is imperative that I get a little bit more detail of the cholesterol and, of course, the underlying disease the patient may have. Now, as you probably all are aware in our enlightened audience, that we no longer just merely look at the total cholesterol level. We look at the components of the cholesterol in terms of the two major components that we're concerned about. One is called the LDL, or low density lipoprotein. That is the dangerous component of the cholesterol. The one that is deposited into the arteries, and especially concerned here with the arteries of the heart, which can block these arteries and can lead to changes which further potentiate the development of blockages, such as to cause heart attacks or angina, that is chest pain, things that suggest to the heart muscle that the heart muscle is not receiving enough blood. But this is a long-term phenomenon. Now, the HDL, the other component, the other major component that we look at with the cholesterol is the good cholesterol. And that's the one that tends to remove the cholesterol away from the bloodstream towards the liver and get rid of the cholesterol, such as to prevent its deposition into the arteries throughout the body, and especially, of course, in the heart and the brain. So this is a long-term process. And when the cholesterol is abnormal, I do not necessarily prevent the patient from having surgery, especially if it is urgently required. What I do is caution them and treat them in terms of how to diminish the LDL, or the bad cholesterol, for the long term. But short-term effect, I still clear them for the surgical procedure if that is all that is present, without already them showing signs of heart attacks, previous heart attacks, or impending heart attacks, evidence that the cholesterol has already wreaked damage on the arteries to the heart and the heart itself. So I look for that, but I also will clear them in regard to the level of the cholesterol for later control of the cholesterol and for preparation for the surgery. I am on call and get a few calls, so please expect that I will. If you'll have to excuse me if I get interrupted every now and again.
No problem, doctor. No problem whatsoever.
But Dr. Athley, is there any circumstance where a very high cholesterol will prevent you from clearing the patient initially?
Hardly, especially if the surgery is urgent, because I'm much more concerned about the cholesterol, not causing an immediate problem, but a long-term problem. So I tend to clear these patients and maybe aggressively controlling the cholesterol after, or if I have a little time before. But generally, it's a longer term concept and not short term.
All right. We also get worried when the blood sugars are not under control. In the acute situation, in the diabetic, especially if it's from an infection, it may be something that can't be controlled until the infection is actually taken care of. But in the elective setting, in a diabetic patient whose sugars aren't under control, we tend not to operate on them because the complication rate goes up. So the wound infection rate goes up, the healing problems also go up. So in those patients, we like to make sure that their blood sugars, at least for a particular period of time, are under control.
Right. Well, what I've always been concerned about, especially from a critical care point of view, is the healing aspect with diabetics.
Yeah.
It seems as though they just don't have the ability to heal appropriately, and in that low healing or non-healing, then infections are the problem.
Yeah.
There's something called sepsis where bacteria, and unfortunately we have bacteria throughout the skin, all over the skin. And there are areas there that bacteria is able to get into the wound, and from there it gets into the bloodstream, and sepsis is that concept of bacteria being in the bloodstream. That has various effects on the body. All of them seems to be bad. Your blood pressure can decrease simply because of the way that the bacteria reacts. Is acting on the body, and the blood vessels don't contract or hold the blood pressure as well. As far as pneumonias are concerned, once there is a bacteria in the blood, the body works as a unit. It's not one area of the body not being associated with the other. Once that bacteria is in the blood, it seems as though it can go into any organ, and pneumonia is one of the things that we really worry about post-surgery, on the ventilator, and being able to manage that patient as far as their blood pressure, as far as fever, as far as allowing them to breathe appropriately on the ventilator, and healing and getting them off the ventilator is always more difficult if there's an infection, and with diabetes, that chance of infection increases. Yeah. I think that there are several other things that I'd love to cover. Please note, if you're out there, and not if you're out there, those that are out there listening to us, if you're near a computer and you can type in your question, please type in your medical question. We're here eager to answer your questions. Now, there's something that, and it's always bothered me, and I'm gonna pose this to everyone. The fact that Black men don't like to go to the doctor, and it's a problem in our culture. It's a problem that we as physicians see in the hospital all the time. It seems as though that our young men and our older men, and it doesn't matter what age they are, they don't like to come. And when they present to us, they present in a stage of illness that's usually more severe. Can we get a conversation about this as to why, what we can do about it, how we can encourage, and let's just start it off. Kevin, can you start us off, and we'll just go across?
Sure. I don't like to go to the doctor either. I mean, it's one of those things, you're conditioned to go to the doctor when you have a problem. And if you don't have a problem, you don't go to the doctor. Now, one of the things that you have to understand is you are susceptible to different things at different ages. So if you are at risk and you become, or your risk level for certain things increases with age. So prostate cancer, colon cancer, hypertension, diabetes, all of these things over time, given your family history, you potentially become at risk, even if you are feeling well. So it's partly being educated to understand I may be completely fine and have no symptoms, but in order for me to ensure that I am not or I won't present with something late, I have to undergo these screening and preventative measures. It's one of those things, very difficult. I can only speak for myself, but I know most people don't go to the doctor unless they have a problem. But you're supposed to go in to have these preventative the procedures and measures.
Yeah. And you're right, Kevin. I think we as physicians, Black physicians and male, we're guilty as well to a certain degree. Do you think there's a certain cultural component to it?
I'm not sure. I mean, I think a lot of people don't like to go to the doctor. You go to the doctor, you may get bad news. You go to the doctor, they may tell you something you don't want to hear. You go to the doctor, they may say, well, now your blood pressure is high, lose weight, exercise, or you're gonna need to be on this medication. You go to the doctor, they may tell you, well, you are going to, your sugars are out of control. You're gonna have to change your diet. So a lot of times it's associated with, even though it benefits your health, it's associated with things that we don't want to do. And because we don't want to do it, that prevents us from going to the doctor.
Right.
Yeah, it's much easier to make the observation than an explanation for it. If I take a very simple, one of the commonest complaints that people come to me with is, of course, chest pain. And although heart attacks are seen more frequently in males and at a younger age than females, yet if I think of all of the patients, the younger patients under age 50 who present with chest pain, they're overwhelmingly female. And so for some reason, my males don't complain as much or come to see me as much with early complaints of chest pain. Now, the question is why, and you raised, there may be many points, they're cultural, they're the ways we're viewed in society, what is viewed as a weakness, what's expected of a strong man versus a complainer kind of thing. So there may be many reasons. It's more difficult to explain why, but the observation I've clearly made that I do see females, especially at a younger age, more frequently in a situation which I would think would affect males as much or more than females. So the question is why?
Yeah. Dr. Court, I see you're eager to
I
jump in
have
there.
to. Audience, most people, especially from the Caribbean and I guess Africa, they're only sick if they're in pain. If they're not in pain, they are not sick. They will not seek help. I get it all the time, but doc, I feel fine. I'm not in pain. In many cases, by the time you get pain, you don't have too much longer to live. I always remind them that when cancer starts, it doesn't cause pain. And when you have pain from most cancers, it's about time that you're about to leave us. So what is the problem with them? We just have to do re-education to let patients know that pain is not the only manifestation of sickness. It just is not. We just have to take our health seriously. Look at what insurance companies are doing right now. They pester the patients. I haven't seen any physical this year, and until a physical is noted by the insurance companies, they will keep calling that patient until they get tired, and eventually the patients come in. But the bottom line, in my experience, if you're not in pain, you're not sick. But that's a fallacy. It's not true. It's better to catch things early before they present with pain.
True. Excellent.
Omar, I think, we are so used to seeing ourselves as gatekeepers and that we need to demonstrate an element of strength at all times. And none of us like to feel that we're vulnerable. And part of the problem is when you start to seek medical help and go to the doctor, you get the feeling that you're exposing some vulnerability. And I think we need to try to change the narrative and say, health maintenance is really a sign of strength, and is taking a proactive approach. There are certain conditions that, whether you're genetically predisposed or you're environmentally predisposed and can't change that situation, where it comes down to identifying early and implementing management strategies. And that's ultimately what's going to give you your longevity. And I think, if we can change the educational aspect of things, screening for blood pressure, screening for diabetes, managing that hemoglobin A1C, going for your colon cancer screening, as Kevin talked about, getting, mammograms, but also look for collaboratives, right? So, if you have a spouse, if you're going to encourage her to go to her doctor to get her wellness check, then, make it a couples event or a family event. We see women do it, sisters get together and they go as a group to get a mammogram and then subsequently go have lunch and get a manicure and a pedicure. However we do, whatever we can do to encourage each other to do it, that's what we should do, and try to move away from the idea that, if I go to my doctor just to check, I'm exposing potential vulnerability because I don't want to hear something potentially wrong. We need to get away from that.
Mhm. Yeah. So,
Wouldn't it feel good to be told that everything is fine?
yeah,
I
but
Yeah.
yeah, that is so true, Dr. Core. But that one little, I think what's holding many of us back as males is that one little possibility that we may not be perfect. And we as males want to be perfect, and that is true. But we have to, as you said, Dr. Anderson, we have to change that narrative. Yearly checks is a must, and it saves lives, and definitely that's what we're here to do. Dr. Sprock, welcome. Welcome.
Thank you. Thank you.
All righty. Sorry, everyone. We had a little technical difficulty and it was on our side. So we will move forward. Our topic today is pediatrics. And I know we've had great discussions on other topics, but let's get to the topic at hand. Dr. Sprock, and I want to start you off with something that's, let's put it this way. Once a baby is born, I understand the GYN aspect of birthing and all of that, but from a pediatric point of view, when they hand that baby to you, what do you do? Let me know from a doctor's perspective, what do you do to the baby to make sure, or how do you check that baby out to make sure it's well and it's going to do well for that mom?
Well, the first thing is a sort of a rapid evaluation of the status of the baby. There's a number of different things that you look at, from the respiration to the heartbeat to the color to the tone. And there's a scoring system that lets you know whether or not the baby's doing well or the baby's in trouble, and it's called an APGAR score. And that APGAR score lets you know whether or not the baby needs intervention or not. And you can think of it as if, when the baby first comes out, the baby is very active, the baby has a vigorous cry. But you can imagine that as the babies are born prematurely, they're not going to have the same amount of vigor, the activity, the color, and everything else. And so the first thing that happens is you do that evaluation to see whether or not the baby's going to need some sort of emergent care or some intense observation. But most babies are born healthy and normal, and they go to a normal nursery. Once the baby's in the normal nursery, then you want to see whether or not the baby's able to suck, because at birth, the babies, for the most part, are asleep. They wake up to eat, and they go back to sleep. And when they usually are awake and they're hungry, they have a cry, and that cry is sort of a vigorous cry. And so you want to make sure that the baby is eating appropriately. If the baby is nursing, we encourage the mother to breastfeed the baby, because that's the best type of nutrition that the baby can get. And then you want to make sure that in the first few days of life, the baby doesn't have a color change like jaundice, which is fairly common in many babies, that they turn a yellowish color. And you make sure that if the baby needs to have a special light to try and help that bilirubin, which is a breakdown product of blood, the baby may have a bilirubin. But by and large, most babies that are normal go home after the first few days of life, unless, again, as I said before, the baby's premature and may need to stay in intensive care nursery or the intermediate care nursery until baby's big enough and out of the danger zone, and then the baby's able to go home.
All right.
The first thing also that's done in the first couple of days of life, the baby may get a shot for hepatitis, and the baby will have a number of blood tests done on a small sample of blood to make sure that the baby doesn't have what's called an inborn error of metabolism or something like sickle cell or hypothyroidism, a couple of things that it's important that they are diagnosed early, because if you diagnose certain of these conditions early enough, you can prevent some of the adverse effects from occurring and make sure that the baby gets the type of care or attention that the baby needs earlier on in life. And then most pediatricians want to see the baby within either the first few days or a week of life. And then at a month, 2 months, 4 months, 6 months, 9 months, a year, 15 months, 2 years, and then after 2 years, it's once a year. So there's a lot of visits, and most of the visits coincide with vaccinations that the baby's going to get. When I first started in pediatrics, they didn't have that many vaccinations. Now there are a number of vaccinations, and these vaccinations that are given are really important because they have eliminated a number of primarily infectious diseases that used to cause a lot of death or a lot of harm to babies if they got it, like meningitis, and a number of the bacteria that cause meningitis now you don't see anymore. And these are bacterial forms of meningitis. They were sort of horrible. When we were on call and babies had high fever, we were doing spinal taps on almost all of them just to make sure that the baby didn't have meningitis, because not only can it cause damage to the brain, but it can also cause death because the bacteria could get into the blood. And so I'm, been very concerned about these anti-vaccine movements that have come about, because people don't realize that the kind of harm that occurred, both death and damage from these infectious diseases that we've developed these vaccines to prevent these complications. And so since you no longer see these diseases or the complications of these diseases, most people think that they don't exist. And yet periodically you'll see that there are outbreaks of things like measles, primarily in communities that don't believe in giving the measles vaccine, some Orthodox Jewish communities, et cetera. But it is important that during the early life, and this is one of the things that you'll see in pediatrics, that a lot of the parents and the mothers might do more for their babies than they might for themselves in terms of getting the medical attention that they need. And so it's over that time that the pediatricians, especially if you are the same pediatrician that sees the baby over and over, then the mother develops a comfort level, and then with subsequent children, you maintain that comfort level. And as Dr. Court was saying, insurance has changed a lot of that. You're seeing a lot more pediatrician practices that are group practices where you may not see the same pediatrician every time you go, or you might see a nurse practitioner, and you don't have the same kind of relationship that you once had when you are dealing with the same pediatrician over and over again. And you'd see some of the babies that you took care of grow up, become teenagers, young adults, and have their own children, and you would take care of them as well. You don't see as much of that as you used to, but it still does occur.
Yeah. You covered a lot of ground there, and and that's great. Let me go back to one thing, and nursing. The mother nursing the baby. Is there an advantage? Is there, protection that the mother is giving the baby by nursing that they do not get from formula?
Well, the first thing I think that's important is that increases the bonding that the mother has with the baby, because when the baby is first born, the baby may want to nurse every 2 hours, which is a lot, which can make it tiring on the mother. But the nutrition that the baby getting is ideally designed for the baby, and the calories are important. But more important than that is that they also contain some of immunologic or protection against certain types of diseases. And so there are certain types of antibodies that are present. And the formula that's made, a lot of it comes from cow's milk, or it may come from soy or other types of plant products. It's not as easily digestible as is the baby. So the babies tend to have less problems with constipation or diarrhea if they're breastfed than if they're given that. And they're less likely to have allergies. The babies can develop allergies to both cow's milk, the protein in cow's milk, or they can even develop allergy to the protein in the soy-based milks. And so there are less problems with feeding. There are less problems with certain types of things like constipation and diarrhea. And although it is demanding that the mother nurse and or pump, especially if they're involved in working where they have to go pump because their breasts are filled with milk, and unless they're relieved of the milk, it becomes painful. But it certainly is the best form of nutrition, and encourage mothers, if they can, to breastfeed at least for the first year of life, but if they can, for as long as they possibly can.
Patrick, did you have a question or a statement?
Yes, for Dr. Sprott. So, the conversation begins even before you get handed that baby. And, at a time when we're talking about neonatal and maternal outcome, is there a collaboration between pediatrician and obstetrician before you get handed that baby from a particular mother? Is there a channel for such a communication to occur that involve both pediatrician, obstetrician, and the parents?
The answer is sometimes, and I dare say that it was better years ago than it may be now.
Totally agree.
In certain circumstances, you would sort of encourage the mother to see the pediatrician even before the baby is born, so they can develop a relationship and they can understand that they'll be in attendance. There are very often relationships between pediatricians and obstetricians, and that was not only because of, I'll say, good health practice, but also there are economic advantages to have an obstetrician that recommends that the mother delivers, and you see them, so that if you develop a good relationship, then they will refer the parents to you. It's always better that you get to meet them beforehand, because number one, you can give them some advice about what they ought to be doing or not doing during the pregnancy. That's sort of in collaboration with what the obstetrician is saying, so that you're on the same page. But also you get to see them, and they get to know that when the baby is born, you will attend the delivery. Now, again, a lot has changed now that a lot of pediatricians no longer go to the hospital. There are hospitalists that are there, but very often there may be someone that's part of the pediatrician group that is in attendance there that might relate with the mother and the baby while they're there, and then they see the pediatrician when they get to there for the first office. But the more you can do that, and again, a lot happens with the type of insurance, whether or not the insurance allows for a pediatrician visit even before delivery is something that may or may not be paid for. But I think it's always a good idea to go. It's not something that's intimidating. It's sort of to just develop a relationship before you actually have the baby.
Mm-hmm. There's a question that just came up, Dr. Sprott. It says, good afternoon, Dr. Sprott. What is the normal range of an APGAR score? So could you explain what an APGAR, how do you guys actually score that, and then give us the normal range?
Yeah, so there are 5 different things that are looked at. And part of it I talked about is the color of the baby, the respiration of the baby, the tone of the baby, the activity and the heart rate. And so each of them can go from 0, 1, or 2. And so if you think of having 2s across the board that have an APGAR of 10, that means that the baby is perfectly normal, not having any kind of concern, any of the parameters that you're looking at. So that means that the baby's tone is good, the baby's cry is good, the color is good, the heart rate is good, the baby is not depressed at all. Remember that sometimes if the mother is having some kind of a distress, the mother might be exposed to medications that might cause the baby to be depressed. And so if you're looking at APGARs that are 8, 9, and 10, you're sort of no concern, because some babies may have some mottling, if you will, that when the babies, remember, coming from the mother, the baby's temperature is the same as the mother's, 98.6. But when they come out into the environment, the baby may be exposed to an environment that's not so warm, might be cold, and might be a little bit mottled. But what you'd expect is that the baby's color would certainly return to normal very, very quickly. But sometimes if babies are born with very, very low APGARs, you're talking about APGARs that are under 5, those are babies that have some concern, are going to need some stimulation. They might need some oxygen in the delivery. They might need something else in terms of that, maybe some brief puffs of oxygen, or maybe some stimulation that might be there. The most important things that you're really concerned about are the respirations and the heartbeat, because those are sort of part of the vital signs that you look at. But again, if the baby's sort of depressed in one area, it increases the likelihood that they're depressed in others. But most experienced pediatrician can look at the baby right away and tell whether or not the baby's entirely normal, or might need a little bit stimulation, or might need a lot of intervention, which would mean having a neonatologist come in and possibly intubate the baby to help breathe for the baby or stimulate the baby. And in some of those cases, if it's not something that's very serious, the babies will respond to those types of things, bagging the baby with oxygen, and the baby's heart will come right back and everything else. If it's more serious, then the baby will need to have not only that kind of support, but also a more extended period of observation. And the sooner the baby returns to a full APGAR, so that we do it at birth, and then there's a 1 minute, and some people do it 5 minutes in terms of the APGARs. So if it's a very low APGAR at 1 minute, but it's better at 5 minutes, then that's a good thing. If it's still low at 5 minutes, that means that the baby's likely headed to either an intermediate care nursery or the intensive care unit.
Yeah. There was another question. What about murmurs? There are babies that, young children as well as babies that have murmurs. How do you handle that? How do you detect it? Dr. Atherley, maybe you can chime in as to some of the murmurs. Are they important? Should we leave them alone? Should they maybe have surgery with certain murmurs? This is an aspect that you hear all the time. My baby has a murmur. How do we let the parents know where we are as far as that is concerned?
Well, again, at birth, the baby has a quick evaluation, including listening to the lungs and listening to the heart. What people don't really understand is really the very different way that the blood is circulating to the baby's heart before birth, and how that changes after birth. Remember that when the baby's in the womb, the baby's not breathing oxygen, so that the lungs are really filled with fluid, and for the most part, the blood bypasses the lung. There's some flow to the lung, but for the most part, instead of going to the lung in order to get oxygen, it sort of goes through a small vessel that goes from the lungs' major blood supply back into the aorta, which supplies the blood to the rest of the body. And once the baby is born, that all changes. And so sometimes that there's, in some babies, that vessel that sort of was very, very functional before the baby was born closes off after birth, but sometimes it doesn't, and that we call that a patent ductus, because that vessel is called a ductus arteriosus. But in those cases, then that may be an issue in terms of what happens, because they can tie it off, or they can use some medication that tries to tie it off. But you try and look and listen for things that might be not just associated with a normal course of events during that immediate birth, but if there's a hole between the chambers of the heart, either at the top or at the bottom, more importantly at the bottom, it becomes an issue that may lead to problems if not corrected earlier. The connection between the upper chambers as a normal before birth, but if that remains open after birth, that also could become a problem in terms of too much blood going to the lungs, which may cause problems. So you try and see whether or not there are sounds that are consistent with something that means that there's something wrong with the way that the heart developed that may need correction or not. And indeed, with some of those abnormal sort of birth defects, I'll call it, congenital heart defects, it may require surgery or some type of intervention, which would mean a referral to a pediatric cardiologist for further evaluation. So very often the pediatricians will listen for murmurs, and if they think that there is a possibility that there may be a problem, they'll make a referral to a pediatric cardiologist who will listen and also probably do some preliminary testing, like an ultrasound, that can visualize what the heart looks like and see whether or not there are problems with a valve or a open connection between the chambers of the heart.
All right. Dr. Atherley, do me a favor. Can you just, and I know I threw that word out there, murmur, like everybody knows what exactly a murmur is. Can you explain what a murmur is for the general public, please? You're still on mute, Dr. Atherley, still on mute.
Thank you.
Yes.
Yes, I can mention the general concept of murmurs, and then I suppose discuss those in pediatric age groups. Now, as the heart contracts, valves open and close, and the blood passes from one chamber to another. There are 4 chambers of the heart. The passage of blood usually is not associated with additional songs over and above the closing and opening of these valves. So you hear the lub-dub related to that, the usual heart songs. Now, as if there is an abnormality of the blood flow pattern, this may create a song which is heard between those lub-dub, lub-dub, lub-psh-dub, lub-psh-dub, or a song which comes after, even later. However, this is not always a pathological or abnormal or defining a sickness. Sometimes, under some situations, a murmur may be what is called a functional murmur. Maybe the blood is flowing a little faster, maybe there's a little bit more blood, et cetera, a functional murmur, which does not define or suggest an abnormality of the valves or the chambers of the heart. So in pediatrics, functional murmurs, and I'm talking about even older age groups than those initially alluded to, as the children develop. In young children, they're often heard functional murmurs. And the question of how the pediatrician deals with that, I'm interested to hear how Kendall deals with that. But in these older patients, many of them are referred to cardiologists, and we have the opportunity or the obligation to ascertain whether or not these are functional or whether they in fact define an abnormality of the valves or an abnormality that the child is born with, a so-called congenital abnormality, oftentimes, for example, holes in the heart, etc. So the sound and the timing of the so-called murmur is important to us, but also associated features. When we examine the patients clinically, we look at them and examine them, we see where there are signs of an illness, anything else, failure to develop, or whether we see some other signs, clubbing of the fingers, thickening of the fingers, whether they're blue, whether they're cyanotic, etc. And then we may be asked upon to do certain tests. One of the commonest tests we'll do, of course, is a simple electrocardiogram, or EKG or ECG, as it's variably called. Simply an electrical recording of the impulses that traverse the heart, an EKG. That can give us a clue as to whether any of the chambers have been involved secondarily or primarily in the causation of the murmur. We may go beyond that. The next commonest test, I would imagine, is an echocardiogram. Now, this is an ultrasound of the heart. This may define for us the structure of the heart, of the muscle of the heart, the structure of the valves, where they're opening adequately, where they're opening and leaking, or where they're sticking and not opening fully. It can define for us holes in between 2 chambers in the heart that should not be communicating. So the echocardiogram tends to be a very, very important factor in deciding on the nature, the causality, and the severity of these murmurs. But I would say that functional heart murmurs may be far and away the commonest heard in childhood, and do not define any significant disease.
Yeah, thank you very much. There's another question that came up. What is the treatment plan for 2-year-old with croup? Dr. Spry?
Well, croup is a condition that usually results in a sound that is like a barking cough. And it usually occurs in very young babies under the age of 2. And, you know, they say it sounds like a seal or a barking cough. And it usually is involved with sort of the bronchioles and the throat area. In the old days, we had what we called croup tents, which are sort of, I'll say, plastic-sized things that fit over that had cool air that went in. And the cool air tends to help open up that upper part of the airway and sort of relieves the cough. Sometimes we would say, put the baby in a car, take the baby in a car with the windows open, and that would help relieve the cough. For the most part, it's sort of a mild disease that really doesn't require much in the way of intervention. Again, it's usually caused by a virus. They call it a para-influenza virus. It's not flu that causes a lot of problems with the lower airway or the lung disease. But it can be a little bit scary for the parent to hear. And very often, if it's of a certain degree of difficulty, the baby seems to be struggling, the baby will be admitted and just put in a misted tent that will help relieve some of the noisiness of the cough. But invariably, it relieves itself within a couple of days, and the baby's able to go home.
For Dr. Bay and Dr. Sprott, I know one of the common problems with, from a respiratory standpoint with children is asthma in young children. Can you both talk a little bit about the incidence, the causes, the different types, and how they're managed?
Yeah, well, asthma is, I'll say, is a chronic respiratory condition that usually is associated with a certain degree of inflammation. There's been a connection, if you will, between a virus called respiratory syncytial virus, RSV. And you might have heard about a lot of admissions to the hospital of young babies within the past couple of months. And these seasons occur around the same time. So RSV, respiratory syncytial virus, as well as influenza occur in the same time when the weather starts to change in the fall. But the respiratory syncytial virus causes damage to the lower airways, to the bronchioles. And the virus invades the cells that line the airway, causing them to be destroyed, which results in cough as well as wheeze. And there's been a connection between babies that develop RSV and certain other kind of viruses, and then predisposing them to develop asthma. And asthma is a condition usually resulted of 3 things. 1, the muscle that surrounds the airway contracts, making the airway smaller. There's a certain amount of inflammation of the airways where there's swelling of the tissue around the cells, which also narrows the airway. And then there's an increased amount of mucus that's there. And so invariably the babies will have trouble breathing with wheezing. And what happens is that the babies have most of the trouble when they're breathing out, which means that there's a certain amount of air trap that exists. And so they can't, when they breathe in, the airways open up a little bit. And so a lot of air is able to go in. But when they breathe out, these airways cut off before all the airway leaves. And because they're moving a smaller amount of air, in order to keep the same amount of air being moved over the same amount of time, they have to increase the number of respirations that they have. So a baby might go from having a respiratory rate of 30 per minute to up to 60 per minute, which means they're breathing twice as fast to move the same amount of air. And so part of the treatment of asthma is to use medication like albuterol, which is inhaled, which relaxes the smooth muscle and allows the airways to open up a bit, which allows the babies to breathe a little bit better so that their respirations will slow down a bit because they're improved. But another important medication that's used is something to deal with the inflammation, usually a steroid. And again, the best type of a steroid is usually if it can be administered topically to help decrease the inflammation of the airway itself. And very often you might see a combination between an albuterol and a steroid via inhalation that helps to open up the airways and helps the baby to remove some of the mucus and actually breathe a little bit better. Now, a lot of the babies, remember that if you're a baby, your airways are a lot smaller than if you're an adult. And so it's easier for you to have these airways cut off or develop problems the smaller that you are. As you get older and the airways gets bigger, even with a little bit of contraction of those muscles, you might not have the symptoms. So a lot of individuals that have asthma, that have these asthmatic attacks, will get better over time. But it's important for the parent to understand that there may be certain triggers that might cause an asthmatic attack. And in pediatrics, the two major triggers are upper respiratory tract infection, and the second one is allergies. And so a lot of the allergies that kids are exposed to are seasonal allergies. It could be dust, it could be mold, it could be grasses, it could be tree nuts, it could be all sorts of things like that. Exercise is another possible trigger in an individual. And if someone has exercise-induced asthma, they may start to wheeze when they start to exercise. Exposure to cold air or exposure to certain irritants like cigarette smoke or things like that may be also triggers. And so if you have those kinds of things that you can avoid, you try and avoid them. Certain things like things that are in the air, like ragweed or things like that, you can avoid. But you need to have medications that you can take to relieve the sort of symptoms of asthma, and especially if you can pick up on them early on. And so what we try and do is we have for the children an asthma plan, which means that there's certain medications that might be used earlier on. And then if the symptoms start to get a little bit worse, you can add additional medications or increase the dosage of some of the medications that are used to try and control the asthma to prevent hospitalization or a trip to the emergency room. Asthma still is the major cause of hospitalization in pediatrics and the major reason that kids miss school in the country. And it tends to run in families, and people that have family members that have asthma, they kind of understand what the symptoms are and the progression. But it's very, very important to look at the various types of triggers that you might have and think of some of the different medications that might be used, especially if you have allergy versus things like a infection.
Mm-hmm. Yeah, Patrick, I want to chime in on that. This is such an important aspect of child care and, our children, and especially I think Black children, because we're exposed to so much. I mean, there are different things like Dr. Sprock has said, even things like cockroaches that are in the home and things we may be exposed to smoking. But let's just talk about several things. You mentioned, Dr. Sprock, asthma plan. That is such an important aspect. When you see your doctor, your pediatrician, you should have a plan that you can follow. If you know your child has asthma, you should have the medications that should be given at what time and at what point you take your child to the emergency room. An asthma plan is so important. There's something called a peak flow that children that are old enough that can do this. It's a way that they can blow into a particular device that gives you an understanding on how open their airways are and how much difficulty they're having breathing. Just let me bear with me just for a minute, but there are several things you've opened.
Omar, I'm afraid I'm gonna have to leave because I have to take my wife somewhere. So, but thank you for allowing me. I apologize for being late, but thank you guys.
All righty, we'll see you, Dr. Sprock. Thank you for chiming in. We will forge ahead.
Okay.
Definitely.
Good question.
All righty. Okay. So let's talk about family history. Family history is so important. If you have a family history, you have a brother, sister, mother, father, even grandparents that have asthma, then there's a likelihood that you may have asthma as well. Understanding that asthma is not an infectious problem. Asthma doesn't carry infection with it. You don't have to give antibiotics to any asthmatic to get them to do better as far as their breathing is concerned. The difference between bronchitis and asthma is the fact that bronchitis is an infection in the airways. Asthma is, for some reason, be it an irritant, be it an allergy, be it some reason, the airways are going into spasm, there's increased mucus production, and difficulty breathing, and the airways get narrow. I've noticed, and the old books used to say, and I don't hear this very often now, that asthma is a bimodal disease. And what do we mean by that? Basically, what they're saying is that as a young person, there's a good chance that that young person, if they truly have asthma, they will have symptoms and will have asthma attacks as a young person. And then somewhere in your early 20s or late teens, the disease actually gives you a break. You seem to improve all of a sudden, and it's not as severe, or it may go away, the symptoms may go away completely. And then as you get older, in your 30s, maybe your 40s, it may come back again. What I feel is that initially, as Dr. Sprock stated, the airways are very small, so the likelihood that you get spasm and occlusion with mucus and those airways are tougher to carry the air through, you get more symptoms as a child. As those airways get larger, you may have less symptoms, but as we live, we come in contact with different things so that our lungs at 40 are not as resilient as they may be when we were 15. All right. So now we come in contact with smoke and everything else, so that entity of bronchospasm and mucus production and things like that, because we walk by a barbecue pit, may start coming back again. So understand that there are a component of asthmatics that may not see or may not have that initial problem, meaning that as a child, they may not have had asthma. All of a sudden, they become 35 years old and they say, wow, I have asthma, but my cousin had it, or my brother had it, or sister had it, but I never had it. Why am I having it now? Or there are other patients, and a certain percentage of patients that may have asthma as a young child, and as they get older, they truly grew out of it, and that's the grow out of it stage. So mostly it is a bimodal disease, but there is that component of early and late asthma presentation. Understand that asthma is a expiratory problem. And what do I mean by that? Expiratory means that when you're breathing out, that's when you hear the wheeze. On expiration, I heard the wheeze. Now, that's asthma. If you have a wheeze or an extra sound on inspiratory, meaning you breathing in and you heard the sound, that usually is not asthma. That's usually not associated with the small airways and the intermediate size airways and the larger airways being going into spasm. It usually is that inspiratory wheeze is usually secondary to an upper airway problem. And what I mean by that is that your vocal cords may be in spasm, or some kind of obstruction in the upper airway near the vocal cords or right below the vocal cords. That's where the obstruction is, and it's not asthma. And you can find this in patients that may have vomiting or esophageal reflux, meaning that the acid refluxing back up into their throat, and they have swelling around their vocal cords because of the acid and things like that, or if there's a lesion or a mass or something up and around the upper airway, and you get that type of problem. Understand also that there's intrinsic and extrinsic asthma. And what do we mean by that? Extrinsic asthma is asthma triggered by something outside, meaning that either there could have been an infection, or like an upper airway infection that could have triggered it, or it could have been, you could have been walking around and past a barbecue pit where the irritants, or breathe something that you're allergic to, or something like that, that could trigger your asthma. Intrinsic asthma means that there was nothing that triggered it. all of a sudden you wake up and you're wheezing, or you're just walking and all of a sudden you just start wheezing. That's intrinsic asthma. But it's all treated basically the same way, with medications that will allow the airways to, and those smooth muscles that are around the airways to relax and allow that airway to open up, number one, to decrease inflammation or swelling or within the airway, and decrease mucus production. And that mucus production is what clogs the airways that prevent you from being able to breathe appropriately. Hopefully I covered that and in a way that everyone out there could understand. And I must say, if you have questions, please type them in, because we're here to answer those questions.
A quick
I
question.
I think though,
Go ahead.
Dr. Front left, but one of the things I think is a little bit confusing in kids, say you present with a cough and a fever.
Mhm.
How do you differentiate what's a viral infection that's going to be self-limiting versus a bacterial infection that needs aggressive treatment and antibiotics?
Yeah, that's a tough one. And
Dr. Sprott left just.
that's a tough one. You know what and Dr. Court may be able to chime in on this as well, because from medicine, you know, what I find is that most infections start off as a viral, and that viral infection has a life cycle. And most of the time, you do not need antibiotics for a common cold or something that is going to, have that cycle from 3 to 7 days, and and you're going to be better. But there are times when that mucus and the cough and the irritation becomes so great that bacteria loves mucus, just absolutely loves mucus. And if you have mucus built up in your airways, that bacteria can grow. And that viral illness all of a sudden becomes a bacterial illness. And when the bacterial illness develops, well, guess what? Then you need antibiotics. So initially, it usually is a viral, and then it changes to a bacterial. If it lasts more than 3 to 5 days, I would say, yeah, at that particular point, we need antibiotics, and maybe a little more aggressive. But before that, the cough medicine, mom's chicken noodle soup, as long as you're not short of breath, meaning that the child is not turning blue, the cough isn't so bad that you're having chest pain, the mucus is not clogging up the airways to the point that the oxygen is low. Usually you can get away with just a viral illness, just treating it at home. But if you start having signs that there is more of a problem than just a simple cold, you need to call your pediatrician or take the baby or the child to the emergency room.
I think, Omar, if I might make a comment, two things just happened. Dr. Sprott left, but here comes Dr. Aluya and Dr.
He's right on time.
We missed him for a while.
All right, but
Yeah.
wait a minute, Patrick, hold your thought. We never introduced ourselves today because of the way we started, and we started a little out of whack, out of order. So I'm going to take a moment, and Dr. Salam, I see you driving, brother, but you came in anyway. I love it. So I'm going to have everybody introduce themselves. Dr. Clark, please introduce yourself, and because this is halftime.
Sure. Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist. I work at Newark, Beth Israel. Glad to be here.
All righty. Dr. Court, could you please introduce yourself?
That's James Court. My practice is in East Orange, New Jersey, internal medicine.
All right, thank you. Dr. Patrick Anderson, please.
Hi, everyone. It's Dr. Patrick Anderson. I'm a GYN oncologist. I work at Newark, Beth Israel.
All righty. Dr. Trevor Atherley.
My name is Trevor Atherley. I'm an interventional cardiologist and predominantly at Newark Beth Israel Medical Center.
All righty. And Dr. Salam, I know you're driving, but you're on mute. I don't want to. Oh, there you go. Go ahead for me.
Good afternoon, everyone. My name is Dr. Kareem Salam. I'm a board certified adult and child and adolescent psychiatrist. I apologize for joining late, but the benefits of a traffic jam is that I could participate in the webinar safely. Delighted to be here. And I work in the city of brotherly love and sisterly affection, more commonly known as Philadelphia.
Excellent, excellent. And Dr. Aluya, welcome.
Yes, thank you very much. And I'm sorry for joining late. I was got engaged in some other engagement I couldn't get off, but I was rushing to get out so I could come join my brothers here. So we do what we do best. Nelson Aluya, Medicine Pediatrics, currently the Chief Medical Officer of the Newark Community Health Centers here in Newark, New Jersey, serving the Essex County area. Thank you.
All right, thank you, Doctor. And thank you for joining. Dr. Sprott, Kendall Sprott, has been holding the chair for you, and he had to leave because he had some family obligations. Dr. Anderson, you had hold on for a minute. Let me make sure that I do everything here. Number one, I'd like to thank OBHealthy for allowing us to have this platform and bring this platform to you. So I'd like to thank them. They are, an organization, and they're your healthy life source. And you should check them out, check their website out, check their app out, and see exactly what they're doing as far as African Americans and health is concerned. The one thing that I can say, and that's most important, is please do not change any aspect of your medical care before you consult your physician. Only your doctor, believe me, only your healthcare provider can truly take care of you appropriately from a medical standpoint. All righty. And please type your questions in. We're here to answer questions. Dr. Anderson, go ahead. Yeah, I know you had something to say.
Yeah, and it's good Dr. Salam and Dr. Aluya joined. In terms of from a categorically perspective, I always say youth is wasted on the young. So just when you figure out how to live life, you start to encounter ailments. And I think you should be born with everything that's going to ail you, and your ability to become a productive adult depends on how well you overcome those ailments. But that says, as a parent and as a healthcare provider, we encourage parents to see their children's development in a way that's parallel to the things that we focus on for ourselves. The big difference is, we can recognize symptoms and verbalize them. A child, depending on their level of development, may or may not be able to verbalize some of the things that ail them, whether it's physical or emotional. And one of the struggles I have is, how do you educate parents as to how to evaluate their child in a manner that's similar to how we evaluate ourselves from a health maintenance perspective? Yeah, when you become 40, you get a mammogram. When you become 50, you get a colonoscopy. Are there timeframes where you take a child and you say, this needs to happen, these are the things that I need to pay attention to? A child may not complain of an abdominal pain, but if there's a bulge in the groin, what does that mean? Dr. Aluya, how do you educate a parent with respect to how you focus on your children and what might be going on with them?
Well, thank you for that question. And as you know, there's no textbook for raising up a child, period. Nowhere, any day, anytime. However, we as a people, not just, I use the word as a people, generality, as humans, we've evolved to where we are, separate from other sapiens and other creatures, because we developed the mindset to be able to think, rationalize, culture and culture, values that we pass from generation to generation. And that's why we are as a people. So we've learned from one another, and we have passed what we've learned from time to time. Now, coming to your question, there are resources out there, resources within your community, resources within your family. I'll begin with resources within your family, meaning mom, dad, father, uncles, aunts, all of those. That's what we have, which was the initial nucleus for what we need to learn and how to move on. Because remember, again, all of these things based on culture, the food we eat, the music we listen to, the way we dress, all of those ultimately affect or influence the kind of services that we seek and how we get them. Even religion as well. So now that nucleus family help you to build all of those. And then you have the community, meaning, your church, your local, tribal or whatever community that you have. And then you have the bigger community when you have the resources, as in school, government agencies and all that. And of course, we have the global perspective where we have books and now the internet. So coming back from all that, as a parent, you need to first of all see who you are, where you are, and your needs, and what goals you want to achieve for your children. And that's the nurturing aspect of it as we begin to develop and raise our children up to where we're building our mindset, building our emotions, building emotional intelligence as well. Because that's one thing that a lot of people don't build up on. Now, when it comes to structural issues, meaning school, example, vaccines and all that, of course, the government has laid things down that, especially in this country, if a child is born, from day one, they have screenings that they do. I'll take them from day one, before they're born. Once a woman gets pregnant, there's a process of what you need to do, how you need to do ultrasound, the tests that you need to do, including HIV. Every mother, when you're pregnant, gets screened for HIV. You know that, Dr. Anderson. You understand? So those are government regulations that have been put in place. As the child is born as well, there are also regulations that have been put in place that every institution and doctors must know and follow as well. For instance, a child is born today. Ab initio from the labor and delivery room, they do the heel stick where they check for like 42 diseases, including thyroid disease, including all of those, sickle cell screening, all of that. We do that. Now, we also do the vaccine, hepatitis B. Every child gets it before they leave the hospital, unless, of course, there's another reason for it. Now, as you go home, it's set up for you to follow up with your primary doctor. Every child wants to leave the hospital or to have a primary care doctor. That's who will follow each and every one of these as we move on. But as we know, in our community, well, judging from the studies that show that you're more likely to do well or live a better life if you're taken care of by those who look like you. But how many of us that look like us take care of us? That's another issue. So, and that's where the explicit and implicit biases come upon that begins to express itself and shows to a point where we have healthcare disparities. And now, as providers or healthcare providers, doctors and nurse practitioners and everybody else that serve in our community, our role is to be the gatekeeper for that. First, we must educate ourselves for the things that we need to know so that we can further educate our parents, educate our communities for things that they need to be aware of, need to see, and need to champion as well. And that's why this platform is here for. We're educating our community so that our members in the community will know when to say, you know what, if a child has a lump in the groin, what does that mean? If there's a spot in the scrotum of a male child who is 14, what does that mean? So that we begin to point them to those directions that will help save their lives and improve their quality of life. Where we also inform them that there are vaccines that they need to take at a certain time to help reduce the infant mortality and morbidity in our communities. Why they need to take their blood pressure check at age 10, why they need to screen for diabetes when they are obese at age 10 or age 15, why they need to get the hearing screening done, because that can affect every child who comes to hospital, to school, who can hear well. If we don't do those things early, we will not know that. So that's where, as a provider, we need to educate ourselves and know what those policies and mandates are so that we can further, empower our community to help reduce healthcare disparity, improve quality of life, and save lives.
Yeah. While you're talking, we have several questions that come up. And let's get this one question because and the other one, it pertains to an adult, but I want to go with the one that pertains to the child first. My granddaughter is diagnosed with something they called a tick. Now, the doctor called it a tick. They live in New Jersey. Can someone explain this? I have never heard of this diagnosis before, a tick.
Yeah, you want me to take that, or Dr. Salam?
Yeah. Go ahead, Dr.
Okay.
Lucia.
A tick is, I'll use the word, is a colloquial word for just to describe a more technical term, meaning it's a common man way of saying there's something wrong with an abnormal movement of that child, meaning either the head or the arm or the leg, that spontaneously moves without the control of that child. That's what it is. It can be multiple things. The question is, when is it happening? Is it happening as a baby? Is it happening as a 4-year-old, 5-year-old, 10-year-old, 15-year-old, 18-year-old? If it's happening, what's the background medical condition of that child? Was the child a premature? If it was premature, did he have blood in the brain? Meaning hemorrhages as a baby from long-term stay in the pediatric ICU? Or is it that it's a grown child that had a trauma or that had an infection, a viral or bacterial infection? Is it a child that has structural problems within the brain stem that is resulting in this? Or is it a child who's 18 that has now been exposed to some chemicals or utilization of drugs that they're not used to? Or is it something that happens also in the family, in other family members? Because there are congenital diseases that are inherited, that pass on from generation to generation. And all of those can actually be autosomal dominance, meaning if one person has it in the family, it expresses itself from father to child to child to grandchildren. So those are questions they need to ask, what it is. It could also be early signs of seizures as well. You understand? So that's where you sit with your doctor. First and foremost, as a parent, you find out exactly when is it happening. Is it happening when the child is excited or agitated? Does the child have a fever with it? Does the child, is it when it's distracted or distressed? Is it when the child is sleeping or awake? All of those questions, you need to document all of those. So when you go meet the primary care doctor or the pediatrician, you can express these things adequately, and they can take the next steps on how to manage this.
Right. Dr. Salam, do you have you heard of this term, and is it something that you would be asked to consult on or talk about as far as neurologically is concerned? I don't know if he can hear me.
Yes, there actually. One sec. Can you hear me?
Yes, we can.
Can you hear me?
Yes,
Okay,
we
excellent.
can. Mhm.
So, great. So, by the way, thank you, Dr. Aluya, for taking that question and your comprehensive explanation. But tics, like many other phenomena in medicine, occur in a variety of flavors. So, tics could be motor. They could involve movements, and they could be simple movements like eye blinking or maybe flexing of the neck muscles so that you make a gesture like that. You could have verbal or vocal tics. There's a specific type of verbal tic associated with Tourette's disorder that involves an impulse to say a curse word or a socially inappropriate word. Now, that type of tic is very easy to remember, but rarely seen. And that's called coprolalia. So in other words, it's the breakdown of that word is like copro meaning feces.
All right. right. Well, hold on just for a second because I know he's driving and he's probably in a low area. All righty. Well, as soon as Dr. Salam comes back, we'll have him continue his thought on that. But his explanation is well, you know what I mean, well deserved, and I would love to hear it completely. We will come back to him. Hold on, there he is.
Okay, all right. So tics could also present as side effects of certain medications that work in the central nervous system. The ones that come to mind most easily are stimulant medications that are used to treat attention deficit hyperactivity disorder. One of the side effects of
Oh. Okay, unfortunately, he keeps coming in and out. All righty. All righty. We're gonna move forward. We're gonna move forward, and when Dr. Salam comes back, we'll see if we can get that full answer from him. There's another question. I have a prolapsed bladder, it states, and hopefully Dr. Anderson and Dr. Clark can help us with this. I was diagnosed with to use and I'm not familiar with this. It's they spell it Pessary.
A pessary.
Yeah, pessary. This can be very uncomfortable at times. Besides the pessary, what would you recommend? Or can you recommend a doctor? And unfortunately, the person lives in Florida. Hopefully, we know someone in Florida. But go ahead. Maybe you can give us some enlightenment on that, Patrick.
Yeah, so prolapsed bladder is equivalent to having a hernia in the groin or on the abdominal wall, and there are several risk factors. One of the more common risk factor is having multiple vaginal births, but also the aging process can be a factor as well. Decrease in the hormonal environment, as in the decrease in estrogen exposure, can be a problem. There are certain patients who have certain chronic illnesses, such as connective tissue disorders. Patients who are chronic smokers with chronic cough can have a prolapse, and the prolapse can be both in the front, as in the bladder, as this participant is explaining, but also in the back, the rectum can bulge forward as well. And there are many different ways to manage this condition. Oftentimes, what's recommended, it depends on the patient's age and spectrum of medical problems. So, for example, when I hear someone recommending a pessary, either it's a short-term solution to a long-term plan. So you're buying some time so you can do appropriate testing, or the patient may not be such a good surgical candidate, may have significant medical problem and can have a surgical risk. Some of those patients include the morbidly obese, chronic diabetes, and chronic heart disease. But that says, it's not one protocol that manages the same people. Also, one of the significant problem is having had previous pelvic surgery, such as a hysterectomy, where appropriate ligamentous suspension was either violated or not restored. That said, not knowing the specifics with respect to this person, the simple answer is a pessary is not the only solution. You need to have a discussion with your provider. There are specialists that manage these conditions. The one that my personal bias is fellowship trained urogynecologist is the best person to evaluate you for the appropriate management. And then there are urologists who specialize in pelvic floor dysfunction. So your primary care can help you identify such subspecialists. And again, like I said, pessary has its place. For the most part, it's self-limiting to the sense that it's not always the best thing for good quality of life. You have to have repeat follow-up where it's taken out and clean and put back. There can be conditions such as pressure ulceration. And essentially, a pessary is a donut-shaped device that's inserted vaginally. and it has a spring-loaded rim that expands to elevate the bladder from coming out the opening of the vagina. So you can have pressure necrosis, you can have ulceration, chronic infections, and so on. And I find that for best quality of life, a surgical management is the best approach. And that surgical management ranges from patients who are elderly, who are not sexually active. You can do what we call a coldoclaesis, or to put simply, close the vagina so nothing protrudes. Or we can do a suspension. You know, Kevin and I have done some of those in the field when we do medical mission, where similar to a mesh repair of an abdominal wall hernia, we use a piece of mesh to suspend the vaginal apex to the sacrum, which is the distal part of your backbone, where it enters the pelvis, and at the same time reduce the weakness in the top of the front wall of the vagina, and reduce the prolapse. So, you know, it's a spectrum of management, and they need to be appropriately evaluated. One other thing I can say is, you know, the reason you need to go through the pre-surgical or the pre-treatment testing is that if you correct this and it's overcorrected, you can go from having incontinence, which is leaking of urine that's often associated with prolapse, and there are different types of incontinence, to overcorrecting it. And now you have urinary retention, which can also have adverse effect in the long run.
Mm-hmm. Excellent, excellent. That's a very good answer. You know, Kevin, do you have anything to add? If not, then we will go to the next question.
Nothing to add.
Okay, good, good. You know, the thing, there was a question that came in is, when should I call the doctor for my child, and when should I call the pediatrician, or when should I go to the emergency room? And they were talking about, as far as fever is concerned, and some of the things that are associated with fever, when, you know, as a mother, or a new mother, or even a mother of a child that's, you know, a little older, fever is a very, very great concern. Dr. Luya, can you give us some enlightenment on that? When to go to the emergency room? I know that fever, you think about severe colds, you think about pneumonia, you think about things like meningitis, and will it lead to a seizure? And, you know, are there febrile seizures? There's so many things that are associated with fevers in children. Can you give us some enlightenment?
Right. First and foremost, I would start by saying fever is not a bad thing. We need to understand that. It's the severity and the persistence of fever that becomes bad if unaddressed. Fever is the body's response to let you know that something is going on, and it's going on potentially bad. But it's also a defense mechanism to help protect and preserve you, and also to help you fight anything foreign that is within you. And your body's temperature goes up, and everybody's body's temperature go up at one point or the other every day, and it's undulating. So, but for children, I know as parents, we get, you know, really antsy and frightened when we hear fever. And that's because over time, that's been ingrained in our mindset as well, because anything can go wrong. And especially if the mother does not, or parent does not know what to do with that. Now, having that said, you know, it depends on when, how old the baby is, and up to what age and what temperature it is. 100.4 and above is considered a fever. And I would advise every parent to have a thermometer at home to be able to check and discuss with your, you know, pediatrician how best to take that temperature. So as you do that, first, don't panic. You carry that child for 9 months. It means you had 9 whole months to get equipped to handle anything that comes on. And you always tell yourself, I got this, first and foremost. And don't panic, and you're a parent and you're in control. That's one. 2, when in doubt, seek help. And you can seek help by asking an older, you know, more experienced family member, or, you know, a member who's experienced who've had a child before, because anybody who's done that understand and know the path and they've taken. And if it's beyond that, call your doctor. Just call, and you have your primary, physician or pediatrician's number, which everybody should have. And it's shocking sometimes when I ask some parents, "Who is your baby's pediatrician?" I don't have one. No, every child should have a pediatrician. Period. So when you doubt, steps, you call. Now, when do you have to call? For instance, if the baby is coming, has a runny nose and all that, has a low grade fever, anything 99, that's not a fever. You can give, a Tylenol. Again, your pediatrician will start calculating the Tylenol dose for you based on the weight of that child for you to give. And that's why it's important to have one and have a connection with that pediatrician so that they can help guide you in this respect. Now, if the fever is persisting over maybe 10 hours or a whole day, then that's something to begin to ask questions. And if it's over 100.4, and all of a sudden the child is not eating, and the child is beginning to look listless or very weak, and or throwing up or anything, or developing a rash, a fever with a rash, not just a rash, a diffuse smooth rash in the body, because we have different viruses that cause HSV6 and 5 and all that. The Mala rash, that children have and all that. Those are not potentially dangerous rash. But if you see a rash that looks like a pimple, a boil that is erupting, and is erupting fast in multiple areas of the body, even with or without fever, that's what I'm trying to call. Call your pediatrician. If they're not answering, take the child to the ER. That's one. Now, if the child is vomiting persistently or having diarrhea and looking listless and tired and fatigued, that's the time to call and seek help. Because children don't pretend. If a child is sick right now and you give the right treatment, you see them bouncing back and running around. And that's the beauty of it. So, but as a parent, once you realize that there's something wrong that's out of the ordinary, seek help.
Excellent, excellent. There are many aspects, and I'm so glad that we're doing this show on children today, because there's so many things that we need to cover. And there's one that you had initially talked about it as far as rashes are concerned. I remember when my children were small and they would develop rash or something like that. I had no clue and I'm a physician, no clue as to whether it was important or not important. And can you also cover keloids as African Americans? There are many of us, and even when we were in Guyana, when we recently did the medical mission, I saw several people that had come to me with keloids, and I can get that experience next time when we have the show and covering our medical mission. But rashes and keloids, as far as our children is concerned, especially with our pigmentation, as far as our skin is concerned, can you enlighten us on something, what a keloid is and whether it's important, whether it's a cancerous problem? Well, give us some ideas.
Right. So I'll take it first with the rash. There's what I call newborn rash. A baby that is born is new, and everything is new. Usually out of the mother's environment, that in the body. So the body would mount a response to the environment, and that response usually increase in the white cell count. Another line of immune system that the child will have to build all through his or her life. And it begins from the day the child is born. So there are some rashes that are newborn rash that are basically benign. And they're prickly rash or heat rash and all those rashes. So, but they're not threatening, especially if there's no fever or any of those things like that. But when you follow up with your primary, pediatrician, they would also educate you in that respect, because they know those things, so that they allay your fears of being worried and tell you what to do. And there are some rashes that come on a baby's face. Oh my God, some of them, they just look like tiny pimples. And then some of them, they become like coalesce and form big, lesions. But as long as that lesion is not like red or weeping or whatever, it's usually okay. And sometimes topical steroids can really low dose topical steroids, that the pediatrician will have to prescribe for you to tell you how to manage them. But if it's not that bad, you may just, light, wet, warm cloth, just rub it over it, tends to really help. However, rashes that can, proceed to a secondary bacterial infection, you would know. They're really angry looking, red and weeping. Those will need antibiotics for. Now, common rash, they're diaper rashes. Diaper rash because of contact dermatitis. Or because the baby is peeing on that rash on the diaper and it has been changed, early enough. You see those rashes. Now, because the baby's immune system is not well developed as well, you can see fungal rash. And those are rashes that you can use topical fungal infections to treat. But God forbid it gets really bad, then you can use oral as well. Now, coming to keloids. Not that many cases you see babies with keloids. Keloids tend to occur as the skin develops, as the layers of the skin build up, from the epidermis to dermis and all the, cornea, cornelis, and all the areas in the skin develop. And as we, or people of color, as the melanin begin to build itself, that's where the risk, occurs. Now, before there are two ways a skin can react to an insult. When I mean an insult, either constant irritation or constant piercing or what of those things, or even infection. There's what they call hypertrophic scar. A hypertrophic scar is not a keloid. It's a total reaction. It's a reaction to a constant irritation from something. And you see the skin begins to grow or big. Maybe there's a foreign body or a little piece of material underneath the skin that wasn't seen. Usually topical steroids will help it go away. Now, when a keloid, for those hypertrophic scars, you see it's usually lighter and it's softer. And once you rub the keloid, steroid, they tend to go away. Or if you remove the source of the insult, it goes away. And it happens on a whole lot of us, everybody. Now, a keloid is a whole different ballgame, where people who have a higher amount of melanin, not everybody, some is genetically coded. You find out that in certain families, they have a propensity for keloids than other families. And you find that some families, you don't have keloids at all. Now, again, that can be a chronic insult, either external or internal as well. Either from food or whatever that they take, or a piercing or something like that, where ab initio you can use steroids. If it doesn't help, that's the time to seek a dermatologist. And the dermatologist can do steroid injections, or they can actually go on to do a surgery as well, just to eliminate it. But there's a whole lot of, what do I call it? Studies that have been going on to see how we can use immune modulants to help reduce, the development of keloids.
Yeah, excellent.
Yeah, and Omar, just to add, we have to be careful. Keloid is interesting because in individuals, they can keloid in one part of the body and not in another. But some of the interventions to decrease keloid formation also inhibits wound healing. So, it's a delicate balance. And oftentimes, we get requests to do a scar revision. And sometimes that repeat stimulation of that spot actually makes the keloid even worse. So, it can be a chronic problem.
Interesting, very interesting. I know that there are issues, or there are treatments. I've heard of treatments like mild radiation to try to prevent this keloid from coming, or that skin discoloration. Have you had that in the past that you needed to direct patients towards?
Yeah, there are several treatment options with varying outcomes. Radiation therapy is one, laser is another, local immune modifier is another, steroid injection is one, overlay of certain substantive material like silicone is another. And it, again, it's not one size fits all. Sometimes you have to try different things to see what works for different individuals.
Right, right. Oh, thank you very much. We only have a few minutes left, but what I'd like to talk about, maybe we could all chime in, because I know most of us, well, I think all of us have children. Well, maybe not all of us. Kevin's yet to jump on that horse, but um, raising a healthy child, back especially a Black healthy child. And, the way I look at it, it's a family affair. And maybe we can all chime in as to what we can do to make sure that our children are healthy. From my perspective, and being in the nutrition and things like that, it's making sure that they eat an appropriate meal, making sure they have breakfast, making sure that at school that they're learning and they're having lunch, and that they're growing as they need to be growing, to follow up with the physician and height, weight, and make sure that things are going well as far as physically as well as mentally, and being challenged from a mental standpoint, and being able to handle the mental activities that are necessary for our children to be bright and to go on and become bright adults. Maybe we can chime in, and you may
Yeah,
have different aspects and different thoughts on it.
Omar, this is an interesting topic that could take up a whole session. I think oftentimes we do what's easy, and that's to focus on the physical aspect of their well-being. You talk about nutrition, you talk about their growth and physical development. But, especially coming out of this pandemic, we're just seeing a whole host of, different mental and emotional conditions and complaints. But I think as a parent, one of the things, we need to focus on is find ways from time to time to assess and promote emotional well-being of our children, and we should not have reservation of engaging professional help. I myself has dealt with the emotional aspect of young people on different levels. Like I said, my own children, but I also once had my own soccer academy, right? And unwittingly was charged by parents to manage the emotional well-being of their children, both from a competitive perspective, a self-esteem perspective when it comes to winning and losing, how to embrace challenges when you're going up against a team that's been well promoted and you're not. And you have to find a way to get these young people to embellish, these challenges. I mean, I remember once coaching a team that we totally beat up from Princeton, totally by, telling a lie, saying to these kids, this is the second best team in the state that has not lost a single game all season. But what a story would it make if an unknown team from Essex County come down here and beat them up? And guess what? By halftime, we were up 4-0, right? So, we need to be very slick and skillful how we approach young people, while at all times promoting their sense of well-being and engaging professional help. And do not get into the whole idea that children and young people are to be seen and not heard. Sometimes from a cultural perspective, that's a practice that we continue to put out there. And, just from an emotional perspective ourselves as an adult, react and say, even asking a kid, well, what's wrong with you? We need to be mindful of how we engage our children and be willing to seek professional help for them.
Good. Any other comments?
Yeah, I would say this, that raising up a child into a healthy, functional, and impactful adult actually begins before they're conceived. You know how the Bible says, he knew your name before you were even conceived? And that's how we must begin to look at it. And why am I saying this? Because the position I am now got me exposed to a whole lot of things But I thought I was such a functioning, great doctor and all that. But then I saw the need in our community and I see the resources that are available to doing this. Now, having a healthy pregnancy starts the beginning of almost everything. And doing that actually begins to have a healthy, firm, intellectually intact, emotionally strong female, because they are the custodians of our inheritance and heritage. There are programs out there. For instance, Healthy Start. If you don't know what Healthy Start is, Google it. I think it's the fourth most government-sponsored program for women. Even before you get pregnant, they identify these women, give them the resources so that when they become pregnant, they would have healthy pregnancy into healthy babies, because that determines everything. Before we begin to even talk about the emotional aspect and building up a character and all that, it really begins from there. So the Healthy Starts, the program that is out there for us to utilize. But even as a doctor, I had no idea that these programs exist. So there are also programs out there that we're not aware of. Now, our job is to inform our community that there's this program, look up these resources and utilize these resources. Now, coming down to having a healthy baby, we're talking about creating a village. We lived in a village, but that village began to get smaller and smaller. And technology and everything else is creating that space in between us to a point where somebody once said in the future, you have to pay to talk to somebody. As we evolve as people, we also understand that we mentally must evolve as well. And knowing that, just like Dr. Anderson say, it is not like what they used to say, children have to be seen and not to be heard. We must also understand that the mind of our children is so different from our mind. They live they've imbibed a virtuality that we never knew or heard before. And they see things through a different mindset. And as parents, we must begin to prepare. Dot all our I's, cross all our T's as we prepare for a child, as we prepare to raise them. Utilize the resources that are available from your doctors, mom, like I said, nuclear family, extended family, community, your doctors, utilize all those resources so that we can raise our children properly. But when you seek those resources to use, see the one that fits you well, not to serve you well, but fits you well, so that you have a great and impactful outcome for your children. Thank you.
Excellent, excellent. Anyone else want to chime in before we end? Because we're just about out of time. All righty. Well, thank you for all who connected with us today. I think we had topics that were so interesting to me, number one, and hopefully they were interesting to you and you've gotten some enlightenment. Let others know about our webinar every second Saturday each month at 1 o'clock Eastern time. Remember Eastern time, because anyone in the world can chime in and come into a computer and type in their question. And please do. I would like to thank OBHealthy for allowing us to bring this product to you. And they're a corporation that's all about health and wellness, especially for the African American and people of African descent. Caring and sharing, let others know, please. And the most important thing, please do not change any aspect of your medical care before you consult your physician, because only your doctor or your healthcare provider can truly take care of you the best. If you missed any of our sessions, our wellness sessions, please go to OBHealthy's website, scroll to the bottom of their homepage and click on the YouTube sign. All of our past sessions and health sessions are there, all of the webinars. Click and view them, take a look at them. All righty. And when you're on that page, please press subscribe so we can continue to bring those YouTube webinars to you. Until next time, oh, I must say, and those of you who are listening next month, it's a special month. And we're going to highlight the Guyanese medical mission and tell you exactly what the physicians have been doing in Guyana over the years. We recently came back from Guyana, and boy, it was a truly wonderful experience. Such great people and such health needs over there that were taken care of while we were there. So next month, be prepared to, we're going to use the first hour to highlight that mission. So important and so happy to be able to do that. Tell everyone that it's going to happen. And until next month, I'm going to say peace and be well. And thank you, each and every one of these physicians that joined us today, and for your knowledge, being, the knowledge that you've given to all of our audience. Thank you. All righty. Peace, everyone. Take care. See you next month.
Thank you, Dr. Bing. Thank you,
All right.
everybody.
All right. We'll see you next.